Qualified, professional, and compassionate doctors talking real solutions to real health problems.
Once again, you're welcome to the Doctalk show. And today we are very honored to have once again in studio Dr. Frank Asimwe Rubabinda, a urologist by profession. You're welcome once again, Dr. Asimwe.
Thank you very much.
And in today's show, we want to demystify the prostate, or to talk about the prostate and the prostate conditions. Right now, everywhere you go, when a man starts becoming of age, and it is even as low as 40 years old now, people are getting very scared. At 40, everyone comes scared, I think, have prostate problems. Not only men, but women are also now getting very, very worried about their husband's prostates. So, Frank, tell us, what exactly is a prostate? Where is it found and what is the prostate?
The prostate is a male organ. It is a 20-gram, call it walnut, cone-shaped organ.
A tiny thing like
Tiny.
this.
Actually, it's the size of your thumb. Whatever size your thumb is, that's the size of your prostate.
Okay.
And it sits just beneath the bladder, where the urethra, the pipe which takes urine out of the bladder to the outside, where the urethra starts.
Okay.
So when the urine is coming out of the bladder, it passes through the prostate and then continues with the rest of the urethra.
Okay. So we have something that tiny that is causing trouble in this world.
Yes.
All right. So what exactly is the use of the prostate? At least we know what the bladder does. We say the urethra brings out urine and things like that. But what does the prostate do? Must men have the prostate?
Yeah, they do. They need it. First of all, it provides the structural support of the urethra as it gets out of the bladder. If that prostate was not there, the urethra would be like a piece of thread.
Okay,
and would
hanging
kink.
around.
And in fact, there are conditions where we have a hypoplastic prostate, the Prune-Berry syndrome. When the prostate is hypoplastic, it's very soft, so the urethra kinks on itself, and actually these children get urinary retention. So first of all, it provides the structure.
Okay.
Secondly, and probably most importantly, it produces part of the sexual fluids.
Okay.
The fluid that males bring out during the sex act is produced from the prostate. So you've got the sperms and some fluid being formed in the testicles. Then when they reach the prostate adds on more. Also the seminal fluids add on more, and then everything comes out as semen.
Okay.
And in the fluid from the prostate, you've got various components. First of all, there is a PSA, prostate-specific antigen, which clears the way. Then there's fructose.
It's like the lead car.
The lead car of the big men.
Okay.
It clears the way. Then there's the fructose, which provides nutrients for the sperms as they flow out. And also there are some antibodies the pH of the semen is very important, and the pH is formed by fluid from the prostate.
Okay.
Yes.
So it's such an important tiny organ to ensure that we have.
Yes.
Now, in order not to take more time on this, I know everybody out there is waiting to hear about conditions that affect the prostate. And because many people think that the prostate issues come in an older age, I know that we have conditions that will affect the younger age and conditions that come with aging. So Frank, could you tell us some of these conditions? In fact, not only some, but all the conditions that affect the prostate.
So the prostate, like any other organ, can suffer from infection, for instance, and that can affect the young and the old. Of course, the very young, like the toddlers and those ones may not have infection. But as you get a bit older, like any of your organs, it can get infection. In the slightly older boys, teens, 20s especially, they can get prostatism. Prostatism is where the prostate has got smooth muscles, as well as other cells which produce the prostatic fluid. Now, these muscles sometimes get into spasms, contract and release. That can cause pain. It can also alter the way we are passing urine. If they contract, they can lead to retention of urine. So prostatism is quite a common condition among the slightly younger, maybe the 20-year-old, early 30s. You've got other growths like cysts. Cysts are small collections of fluid. Again, because I've told you that the prostate is a gland, it produces fluid. Now, when the pockets and the channels for these fluids gets blocked, then the fluid which is being produced can accumulate and cause cysts. Now, these cysts could get infected, but even without getting infected, they can cause symptoms as a result of the pressure they are causing on the prostate. So the person, very young, he gets symptoms of passing urine frequently, pain on the back. We'll talk about the symptoms from just the cyst in their prostate. That's quite a common disease. And then as you get older, you've got enlargement of the prostate. Like you hinted in the introduction, the prostate, like any part of your body, ages. The analogy is your hair. As we age, the hair gets gray. It first gets a little weaker, then to grays. For the men, they begin getting a bald head. So all those are signs of aging. People get wrinkles. I know the ladies fight that so much, but it's a losing battle. Eventually, it catches up with them.
One day to suddenly
yes.
come.
So at the age of 40, the prostate begins aging. And the first manifestation of the aging is it increases in size. It enlarges. So we call that prostate enlargement.
Okay.
And we call it benign prostatic enlargement. And once we've done the histology, we call it benign prostatic hyperplasia.
Okay.
It can be hypertrophy, but mostly it's hyperplasia.
The one we normally hear call BPH.
BPH.
Benign
yes.
prostatic hyperplasia.
Yes.
Okay.
So very common from the age of 40 onwards. Actually, statistically, but maybe we'll get to that, we know that by 90 or by 100, if you are lucky to live up to 100, 99% of all men will have a BPH.
Okay.
So it kind of matches your age. The risk.
The higher you go.
The higher you grow, the higher the risk. The higher you go. By the time you reach 100, you are certain to have had a BPH. The difference is not everyone with an enlarged prostate, not everyone with a BPH manifests the symptoms.
Okay.
And we're going to be elaborating this one further as we reach the treatment. So someone's prostate may actually be enlarged, but it's not producing symptoms. So they never get to know about it because there is no harm. It's just aged.
It's like growing old and your eyes keep fine.
Keep seeing,
yes. They are aging, but they are still seeing well. Okay. Yes. So now, of course, the big elephant in the room.
The C word.
Yes.
The cancer.
Yes.
Yes, cancer is one of the diseases of the prostate, very feared. It has got a lifetime risk of about 1 in 8. At about, generally across all the
So 1
ages.
out of every 8 men will get prostate.
In their lifetime.
In their lifetime.
The risk increases with age. The highest risk picks up at about the age of 60, 70, 80. So they are more in their 70s and 80s and less in the younger ages. But the youngest patient, for instance, I'm treating and diagnosed was 42.
With prostate cancer.
Prostate cancer. Now, the craziest and most scary part, but before I scare everyone, the ones at the younger age are much fewer, much fewer. The ones at the older age, that's where you have got the most. But unfortunately, the ones who get it youngest, it is most aggressive. And the ones who get it older, it is less aggressive. So that's like the flip.
Yeah.
The risk is lower when you're younger, but if
once you get it,
it's very aggressive.
It is terrible.
Yes.
That is very, very serious. Much as we are trying to push our age to ensure that we live longer, stay healthier, but now age also comes with its own problems.
Yes, but of course, as we'll be talking about in the management, when it comes later, like I've said, it is less aggressive and can be turned into a lifelong disease like hypertension, diabetes.
Okay.
Yes, but we'll talk about that in the management.
Right. So in the next section, we shall see the symptoms. How do you know that you have an issue with your prostate? And we shall also go ahead to see who is at risk. We shall also go ahead to tell you about the management. And then, of course, to ensure that we do not scare everybody, Frank will also reassure us that there's something we can try and do to prevent future problems with the prostate. Remember to follow us on our social media platforms, on Facebook, on Twitter, and we shall answer your questions. Doctalk Show.
You are watching the Doctalk Show.
good school doesn't tolerate violence against children.
Because a good school equals a better life.
Raising voices.
I remember the lockdown, when the streets were empty and our lives disrupted, when businesses closed and our livelihoods hung in the balance. Hospitals were full. We lost loved ones, jobs, and hope. Our children couldn't study anymore. We cannot let this happen again. We should not go back. Get fully vaccinated against COVID-19 and join the millions of Ugandans who are already vaccinated.
You are watching the Doctalk Show.
You're still watching the Doctalk Show, and today we are talking about the prostate and conditions of the prostate. Now, Dr. Simwe, could you tell us who are those people that would get prostate issues? You've talked about aging, but let us see if there are some that can escape it.
The risk factors for, say, infection, they cut across the board. Anyone can get infection. And most infection of the prostate can arise from infection of the bladder. So if you have got cystitis, as we call it, which is not treated very well, you can easily get prostatitis. If you have got urethral stricture, you are likely to get prostatitis. So people with other urethral, or as we call it, genitourinary tract infections have a high risk of getting prostatic infections.
Okay, so people with the infections in their urinary system.
Yes.
Okay.
People with stones, genitourinary tract stones, kidney stones, bladder stones, they also have a higher risk of getting prostatic infections. Okay. For cysts, there is no known risk factor. It just happens. But having said that, again, if you have had prostatitis, especially if you have had TB, but usually we diagnose TB of the prostate following issues like cysts. But does not necessarily mean that everyone with a cyst has had TB. But if you've had a prolonged infection, especially if it is tuberculous, then you might get cysts. But
also, now you bring in something new. That means somebody can actually get TB of the prostate.
Oh yes, TB can be anywhere. We call it extrapulmonary TB.
The one outside the lungs. Outside
the lungs. And in our genitourinary system, you can get TB of the kidneys, you can get TB of the prostate, you can get TB of the testicles. The most difficult part of TB in our area is very difficult to confirm the presence of that disease. So it's a diagnosis of exclusion.
Okay.
For instance, you've got prostatitis, which is not being resolved with routine.
That's infection of the prostate.
Of the prostate, which is not responding to the ordinary antibiotics. That can then make you think of TB. You have issues of, say, otitis, like I've said, infection in the testicles, which is giving you abscesses and it's not responding to the ordinary antibiotics. So TB can occur in the genitourinary system, and it's very difficult to diagnose. Okay. But we do. We have to have a very high sense of suspicion. Yes.
Okay, so this small organ actually has issues.
Yes. So apart from infection and cysts, we can talk about enlargement, the BPH. That one, the risk factor is age. Once you clock 40, welcome the real world.
Wow.
Your prostate is likely to enlarge, very likely to enlarge. And in fact, if you realize you are the type who ages, there are these people who have got, who get bald heads very quickly, gray very quickly. Or
are they the ones who also get very moody and
no. If you can just look like you have a tendency to age much faster than your age, then even your prostate is likely to be enlarging, or let's say aging. And as we said,
at the same rate.
At the same rate.
So those people who get gray hair really fast?
Yes.
And balding and
yes, but we cannot use that as a blanket. But suffice to say that
generally
prostate ages as you age. So age 40 and above, the prostate is likely to get enlarged. Then the big C word, the cancer. Now, I need to begin by demystifying the myth of prostate enlargement and prostate cancer.
Okay.
The two may not lead to the other. Having a BPH or of the prostate enlarging does not necessarily is going to become cancerous. So if you have got a first-degree relative, a father, a big brother, an uncle, a paternal or maternal uncle, who has been diagnosed with prostate cancer, your risk increases almost 2 to 3-fold.
Wow, just like breast cancer then?
Yes, it increases. The risk is even higher depending on the age at which they were diagnosed.
Okay.
If they were diagnosed younger, maybe 40, like I mentioned, or 50, maybe 60, the risk is much higher than if they were diagnosed when they were 80 or 90. So family history is a huge risk factor. We talk about nutrition.
Okay.
Nutrition influencing is one of the issues we can prevent. And this, we cannot zero down and say that this person has eaten this, therefore he has this. But studies have been done and looked at the people diet across the world. People who eat mostly vegetarian diet, people who have got, in terms of meat, who do seafood, fish, crab, white meat, that is chicken, the risk of prostate cancer is much, much, much lower than the ones who eat the refined foods, the red meat.
Canned tuna.
Yes. So, like the Western diet, the American diet, the burgers.
The burgers.
Yes.
The
risk
KFC,
is very high.
Sausages, the ham.
Yes, the prevalence is very high. And then they have also discovered that when the people from the low-risk areas on a vegetarian diet immigrate to the countries where there is that other diet, the risk goes up and equalizes the people they found.
We are basically eating pork, which we are calling white meat, which is red meat, very red meat. We are still eating a lot of meat, and then we have changed to the Western diet because we are now all middle income, and all we are eating is westernized diet, and we've gone away from our usual foods. Anyway, we cannot stop underscoring the importance of our diet in prevention of cancer.
But we need to quickly say that cancers don't read these books we are reading from. So you'll eat your white meat, you abstain from everything, and lo and behold, you have it. But generally speaking, for prevention, and the prevention you're talking about is not when you have been eating red meat and now at 60,
suddenly
you abandon it.
You get saved.
This is from toddler age, from when you are teething. What are you eating? Toddler, school time, 10 years, 20 years. That's when the changes begin happening or are stopped from happening.
This is a catch-22. So do we have any geographical variations apart from that?
The geographical variations have been put to the dietary variations.
Together
ultimately.
with the dietary ones.
Yes.
So do we have any other risks that come with that? So we have age and basically nutrition.
Proper dieting and healthy living, exercising, not being a sedentary, being active, all those can minimize the risk of prostate cancer.
And smoking, of course, like any other cancer.
Smoking, drinking.
Okay. So quickly, can we see how we can, when somebody comes to you, to your facility with all these symptoms, how do you tell the difference between that, the hyperplasia you talked about, BPH, the enlargement, and the cancer? Because that's what most people would want to know. Do I have cancer, or do I actually have just the enlargement you talked about?
So if someone has got symptoms, or if you can backtrack a little bit, even before they have symptoms, we advise that. And again, the other risk factor we forgot to mention is being black.
Okay.
The risk of prostate cancer has been found to be higher in black men than in their colleagues, the white males.
We have issues.
So for us, if a black man clocks 40, you begin screening.
Okay.
If a white man, you wait for 45, 50. So if a black man reaches 40, they must screen. And the screening is simple. We just take off blood for a protein called PSA.
Okay.
It's within a certain range, you're fine. If it's slightly higher, then you do other tests, which include an ultrasound and a digital rectal examination.
Okay.
Then depending on the findings, then you can then go ahead to do a prostate biopsy. Ultimately, the diagnosis is not confirmed until you have done a biopsy, and histologically, someone has looked at those cells and said these cells are malignant or they are not.
Okay. So, in short, the take-home message is that all men, at the moment, if you're black and you clock 40, go and see your doctor.
Yes. We've got our urinary bladder, okay, and the urethra, which takes urine out of the bladder all the way out. Now, the prostate sits just beneath the urinary bladder.
Okay.
And in its relations, it is a neighbor to the rectum.
Okay.
So the only way we can comfortably feel, you know, doctors, we like touching.
Yes.
Touch and feel this prostate is by putting our fingers through the patient's rectum.
Okay.
Okay. And then we palpate, we call it palpating. We touch this side of the rectum. That way you'll be feeling the prostate. And I've got a model of the prostate here. You feel for the, you know, how soft or how firm it is, if it has got any undulations, if it's painful. So this will be sitting here like that, and then you put in your finger and feel for it. That's called the dictorectal examination. So the changes which take place, it becomes harder, it becomes more nodular. There's what we call a sulcus. There's a groove in the middle. It disappears. I can spare the rest for my medical students.
Okay. Yes. So thank you very much. We've seen that age, we cannot cheat age. No. All of us are aging. And then for men, as you age, your prostate is enlarging. And you need to have that check. So when we come back, we'll see what can be done. Once you have these prostatic problems, what can be done about these problems? And then we shall go ahead to see how do you prevent, much as you can't prevent your age from progressing, but how can you prevent yourself from getting prostate issues? Remember to follow us on our social media platforms, on Facebook and on Twitter, and to subscribe to our YouTube channel, Doctalk Show.
You are watching the Doctalk Show.
It's back! After 2 years away, the Uganda International Trade Fair is back. The Uganda Manufacturers Association excitedly invites you to the 28th Uganda International Trade Fair from October 3rd to October 10th. Visit more than 1,000 manufacturers, traders, distributors, and business people from all sectors at the UMA Showgrounds in Lugogo. We are back to innovation, products, and world-class manufacturing excellence. Entrance fee is 10,000 shillings only. Select manufacturers will offer discounted prices of up to 50%. Enjoy live performances from your favorite artists as we celebrate 60 years of Uganda's independence. To book space, call 0703 552 444.
The Ministry of Health informs the public that there are confirmed cases of Ebola in Uganda. We, however, urge the public not to panic as the situation is being managed. The Ministry of Health further reminds the public to be on the lookout for any persons who may show signs and symptoms of Ebola. These include high body temperature, abdominal pains, diarrhea, vomiting, bleeding from the body openings such as the nose, eyes, and mouth. Please inform the nearest health worker immediately if you see anyone with these signs and symptoms. To prevent Ebola from spreading further, please take the following preventive measures: regular washing of hands with water and soap, avoid handshaking and hugging, avoiding any contact with any suspected Ebola patients. Any person who dies suddenly should not be buried but reported to the nearest health worker or LC1 immediately. For further information, please call the Ministry of Health toll-free number on 0800 100-066 or send a free SMS to your report on 8500. This message is from the Ministry of Health with support from UNICEF and World Health Organization.
You are watching the Doctalk Show.
Mzee Kortochi is our 72-year-old gentleman, one of our lucky patients. He was diagnosed with prostate cancer in 2015. One of the most important aspects in management is to do proper patient risk stratification. At that time, he presented with a PSA of 20.7, and that puts him in the high risk, but at the beginning of the high risk, because the cutoff is 20, so he was only in the high risk by 0.7. The other parameters, like his Gleason score was 6, that is low risk. His tumor occupancy was 30%, that is also low risk. The MRI confirmed that his tumor was confined to the prostate and not reaching the lymph nodes. That is also low risk. And so the decision was made to do a radical prostatectomy, but do very close monitoring. So fast forward, we did a radical prostatectomy, and lucky enough, the results came out and showed that we had resected the whole tumor. The resection margins were negative. The lymph nodes were negative. So we're on the path. And indeed, 2 months after the radical prostatectomy, his PSA had fallen from 20.7 to 0.1. But we continued monitoring him closely. After 2 years of monitoring, his PSA began rising. It went as high as 39. Remember what? 20.07, we dropped all the way to 0.1. Then we began raising again until we reached 39. Of course, there was a little gap somewhere. And then we now put in another modality, that is injections, which is an androgen deprivation modality. And since he started his injections in 2017, his PSA has been under 0. So this emphasizes 2 things: that cancer of the prostate is no longer a killer if diagnosed, and pretty much regardless of stage. If diagnosed and managed appropriately, it can be converted from a disease one would have died from to a disease one will die with. Diagnosis, appropriate risk stratification, adherence to the appropriate management regimen can turn a disease which would be otherwise a killer disease into a chronic disease, one you can die from, can die with, but not die from.
You are watching the Doctalk Show.
You're watching the Doctalk Show, where we're discussing prostate and prostate conditions. And with me in studio is Dr. Frank Asimwe, a urologist at Mulago Hospital. So we are now looking at the management. We've seen the risk factors, we've seen the conditions that affect the prostate, we've seen how these people manifest. Majorly when it's an infection like we talked about, they will treat them. We shall treat them, I'm sure, with antibiotics. But let us focus on the enlargement of the prostate and prostate cancer. How do you manage these patients? When someone walks in, they are at the age of 65 and they have these symptoms. And you've done your screening, your digital rectal examination, and confirmed that the prostate has enlarged.
So like we've said, prostate enlargement should not be big news because it's bound to happen.
Okay.
So I would like to reassure my old and aging men that once you're told by the person who does your scan that your prostate is enlarged, it's like telling you have gray hair.
Or it's like telling a woman that her breasts are no longer, will face down at one point.
I can't say that myself. It's good you're the one who has said it.
Okay, so it has to happen.
It has to happen.
Anyway.
Your prostate has got enlarged.
Okay.
So our management is focused on the presence of symptoms and their severity.
Okay.
If your prostate has enlarged, however big it is, if it has not produced symptoms, and if those symptoms are not very severe, we are not going to do any significant intervention.
Okay.
In the medical world, is what we've termed as IPSS, International Prostate Symptom Severity Score.
Okay.
And scores the symptoms and gives a rating from 0 to 35. You can leave that jargon to us. We stratify our patients into 3 groups. Mild, that's up to 7, moderate, up to 21, 22, and then severe.
Above that.
Above 21. If a patient has no symptoms, you don't need to do anything. Just tell them, welcome to the real world, your prostate has enlarged. There is no big, don't be worried.
No big deal. Your body is normal.
It's normal. If it has enlarged, but the symptoms are mild, and we have our own way of grading them, we'll ask you several questions, then we do what we call watchful waiting. A few life modifications. For instance, and you need to really be alert to this, you don't have to take a lot of water at night.
Okay.
Because you are trying to stretch a bladder which is facing an obstructing prostate, like we have said. So reduce the amount of water you are taking at night. Don't go for binge drinking. Okay, binge drinking, people who drink, alcoholic drinks, they make your kidneys form a lot of urine so fast. So your bladder is challenged so fast. So we will tell you your prostate is enlarged. Don't challenge it. Don't challenge it. Not
Relax
too much.
a bit.
Yes,
So you're
relax a bit.
aging,
Yes.
slow down.
And when
you're drinking.
And when you feel like passing urine, don't over postpone. So if you can do those three, you don't need any treatment. So that will help you to get from getting your symptoms into moderate. Now, should your symptoms be moderate, and leave that classification to us, then there are drugs we can give you.
Okay.
There are tablets we give you, and your symptoms will normalize. It will not significantly reduce the size of your prostate, but your symptoms will significantly improve.
Reduce.
So many men say, they've said my prostate is 90 grams. So when you give them treatment, they expect it to drop back. They'll ask you what's the normal size, you say it's 20. So will it come back to 20? The answer is no, it will not come back to 20. And that's not the aim of our treatment. It might reduce a little from 90 to 80, maybe 60. But for us, that's not what we concentrate on. We concentrate on the severity of symptoms or removal of those symptoms.
Okay.
Then if the symptoms are severe, that calls for surgery.
We are still on just enlargement?
Just enlargement, not prostate
So
cancer.
what would we call severe symptoms?
A retention of urine more than 150 mils, 100 to more than 100 actually.
So we are talking of this, we said somebody has gone to the toilet and still feels he has not finished.
Then
so we are talking if you're getting 150 mils.
We take him to the scan, we find that there is more than 100, we give them the tablets, and still the volume is not reducing. So non-responsive, maybe we can begin there, non-response to the medication.
Okay.
So the symptoms are not budging to the medication. They are either getting worse or they're the same. To a significant residue, which is also not responding to treatment.
That is the amount of urine that stays in the blood at any one point.
In the bladder, yes, because the prostate blocks the passage and the urine is not coming out. And ultimately, if the patient has gone into retention, and they have to use a catheter.
Okay, because we have the men who say they cannot pass urine,
Yes.
and they are screaming in pain. And
they don't even have to say it. You will see it. They'll be sweating, they'll be screaming,
okay.
and they will not have passed
And you
urine.
can only get it out by catheter.
So as a teacher of urology, if my patient has gone into retention, he has crossed the line, it's better that they prepare to have surgery. It's not an emergency, because once you are putting a catheter, then you have
the urine
time.
keeps
Yes,
coming
keeps
out,
coming.
okay.
The catheter can be changed every month, but ultimately we prepare them for surgery.
Let us first understand, where are you putting this catheter?
So a catheter is a flexible rubbery tube that is inserted into the bladder through the urethra. So it enters the urethra through the male organ, the tube which passes urine. So the tube passes all the way. We've got techniques which take care of all these curvatures, and the catheter sits in here. And we balloon it. We inject a bit of water to balloon the catheter so it sticks in, it doesn't fall out. It develops a head like for a cobbler, like for a snake, so it cannot come out. So it sits there, and we will drain the urine, okay? And we can connect a bag. Usually we teach that we should connect a bag and the urine flows all the time. And we also, what we forget us as doctors is to teach our patients how to live with the catheter and the bag. It's a new thing. They also want to attend parties, and it's very possible. There are bags which can be strapped on legs. We can modify them. You can fold it in just 2 folds and put it in the pocket. Make sure it doesn't fill so fast. Every 1 hour you go and empty it. So a man can have a catheter and still socialize. Normalize.
But quickly, I remember we used to have a suprapubic catheter.
Yes. That is if the passage here does not allow the catheter to pass. The first condition which happens in that is the urethral stricture.
So this tube
blockage.
has closed, has blocked.
Yes, blocked. Or if the prostate is not only enlarged, but also hard and cannot allow the catheter to pass through.
Okay.
That usually happens in some cases of prostate cancer, which we'll be talking about.
Okay.
But generally speaking, in benign prostatic hyperplasia, the catheter should enter. Of course, it depends on who is putting it and how they were taught and how they practice passing the catheter.
Okay.
And we need
Why
to
would you remove part and not? Because if I have an issue with the prostate, please take out this thing and let me be.
Like we said, the prostate has got many functions. 1, 2, it has got many relations. There are organs which neighbor it. So if you aim to remove it in its entirety, which we do for prostate cancer, you're going to be getting into many organs. The bladder itself, okay, the seminal vesicles, the sphincters, these are the brakes, These are for the urine, the rectum. If you aim at removing the prostate, we do it for cancer of the prostate, radical prostatectomy, you enter into the risk of injuring any of those organs. So you need to ask, is this risk worth it? And yet the reason why you are removing the prostate is to relieve the retention. Remember, we're talking about symptoms.
Yes.
We have no quarrel with the prostate, even when it enlarges, but when it begins producing symptoms. So we remove what we call the adenoma, the part which is adenomatous, which has enlarged. Then the other zones, we talk about zones in prostate, remain to continue producing the PSA and other functions. There is more bleeding in benign prostatic hyperplasia than in cancer. Reason being, prostates which are enlarging from benign conditions grow much bigger than the ones which are enlarging from cancer. Now, as they grow bigger, their blood supply also increases. So these blood vessels, which have also begun getting bigger, can easily rupture and bleed, as opposed to bleeding from encroachment from cancerous cells.
You are watching the Doctalk show.
The Uganda at 60 Business Breakfast Conference will be held on October 12, 2022 at Speak Resort Munyonyo. The Red Carpet event will bring together influential business leaders, entrepreneurs, innovators, development partners, and senior government officials. The theme is COVID-19, Conflict and Energy Crisis, the lessons for Uganda in managing geopolitical risk. The guest speaker is Senior Presidential Advisor on Special Operations, Lieutenant General Muhoozi Kainerugaba. Topics to discuss include oil and gas, emerging technologies, job creation, agribusiness, regional trade, and sports and creatives. To participate, call 0705 340 477 or 0701 490 492. Hosted by Kampala Economic Renaissance Foundation in partnership with Afro Mobile, Chiriandongo Sugar, Speak Resort Munyonyo, Uganda Investment Authority, Ministry of Trade and Investment, Subula, Trotbach Energies, and more others.
The Inuka Africa Annual Conference is here yet again. From the 5th to the 8th of October 2022. In the midst of trying times, our God has indeed been our stone of help, and He will bring what He has begun in us to completion. Join this transformative conference as we gather to disciple gatekeepers for such a time as this. Best in 1 Chronicles chapter 26 and verses 12. The conference will take place at the Imperial Royal Hotel in Kampala from 2 p.m. to 7 p.m. Entrance is free.
You are watching the Doctalk show.
So first, when we diagnose you, we categorize your cancer according to the manifestations into a very low risk, intermediate risk, high risk, very high risk. Now, those are about 5 categories. Because of the limitation in our diagnostic capacity here in the third world, we stick to 3 categories. Instead of having very low and low, we say low risk, then intermediate risk, and instead of having high and very high, we say high risk. Low risk is curable.
Okay, very encouraging.
High risk is not curable, but we can palliate it and control it.
Okay, you can help someone live longer. With the cancer.
And in fact, for us, we say, once we diagnose you with prostate cancer, the majority of our patients should be able to die with it than from it.
Okay.
They should
Something else should kill you, but not the prostate
not
cancer,
the prostate
provided you're getting the right
management.
Okay, so now someone has come with cancer and you have stratified them.
Yes.
How do you manage them?
The low risk, okay, the intermediate risks are eventually divided into either low or high.
Okay.
So the low risk, we aim at...
So you remain with just low and high risk?
Two groups. The low risk, we aim at cure, and there are basically 2 modalities, radical prostatectomy and or radical radiotherapy.
Meaning?
Okay? Meaning, we will radically remove this prostate.
So it's radical.
The surgery that people want to remove the prostate. Yes, we do now. We remove the whole prostate with part of the bladder with all the seminovascles, all the way up to the sphincters. Okay, so the whole prostate.
the whole prostate and its neighboring.
A bit of bladder neck, all the seminovascles, and the rest of the prostate. And we do a radical lymph node dissection.
Okay.
Lymph nodes are the sanjabavu, the stations where the troops that fight infection station. Okay, where the stations where the troops sit.
So they're like barracks.
Yes, barracks. They are scattered within the pelvis. So in addition to removing the prostate and part of the bladder neck and the seminovascles, we remove the lymph nodes.
Okay.
So
you
it
don't
is
want
radical.
anything to do with the prostate
No.
now again in that body.
Everything comes out.
So that is in low risk.
In low risk.
Okay. And you're trying to cure the cancer.
And once we do that, whatever we have removed is sent to the pathologist, who then tells us two very important things. One, the resection margins, that wherever we have cut, there was no cancer.
Okay.
So all the cancer is in what we have cut. Two, that the lymph nodes, the sanjabab we have removed, also did not have cancer. At that point, we say we have cured it. But as soon as we say we have cured it, we tell you we have given you a 5-year survival rate. We can only stretch our promise to 5 years, and we assess it as we go on.
So after 5 years,
we will have reassessed.
Okay.
Yes.
And seen
where we are.
Okay.
So that is radical
Prostatectomy.
Radical prostatectomy. Or we can do the same using radiotherapy. Radiotherapy is electricity, to use the crude words, which is concentrated on where the problem is, and you literally kill the cells with fire and electricity.
Electrocute them and kill them. And then for those that we have taken as high risk.
High risk, we palliate.
Okay.
And palliation begins from the understanding that the cancer of the prostate feeds on a hormone called testosterone. Testosterone is the male hormone, is the hormone which makes me male and does not make me Fiona. Now, the male hormone gives me libido, gives me a deep voice, gives me muscles, or whatever you can call muscles, and makes me a
receding
man.
hairline.
Yes. That is what we must go for and remove. And we have two modalities of removing it. Either medically, we give you medications which antagonize its synthesis.
Of that hormone?
Of that hormone.
The making of that hormone?
Yes. Or we go for the factory of this hormone, which is the testicles. So we have our testicles down here. They produce 95% of testosterone.
Okay.
I was about to say we go and bomb them. No, we go and remove them. Once you've removed them, we have technically starved the cancer of the prostate, and wherever else it has spread, whether it has spread the brain or the back or whatever, it has been frozen.
Okay, you stop it from progressing.
From progressing.
What are the complications that will arise, at least from the surgery now?
From the surgery, the immediate complications of surgery, usually in surgery, we categorize our complications into intraoperative, immediate, and long-term. Intraoperatively, this is a very bloody procedure.
Okay, the complications that happen in theater, on the table, as the surgery is going on.
The patient can bleed. These are patients we must prepare, optimize, make sure their blood levels are good, make sure we have blood, and we prepare them, because they are definitely going to lose blood. Although
so you prepare for blood transfusion in case of anything?
In case we need it. But these days we've got gadgets which coagulate as they cut. They stop the bleeding as you do the cutting. Because of that, don't remember when I last transfused my patients on prostatectomy. Then immediately after surgery, there could be infection. That we usually take care of that. So the intra and the postoperative complications, we can get a hand over them very quickly. The feared ones are two. One, the nerves that supply the penis pass just next to the prostate. So as we're doing radical prostatectomy, or as a result of the cancer itself, those nerves are touched or cut. So the patient's ability to have an erection is grossly compromised. It could actually be for the rest of their lives.
Okay, this is not exactly good news.
Not exactly good news.
Okay.
But also suffice to say that whichever modality we would have done, we're going to knock out testosterone anyway.
The hormone that will help you erect.
Yes.
The hormone that will help you be a man.
Yes. But like I said earlier, that one is done for the complicated, for the late, the high risk.
Ones.
So for the low risk, that can happen at a rate of about, no, it's not so high. It's about 15 to 20% of the patients will get erectile dysfunction as a result of that.
Oh, okay.
The second complication, because the sphincters, the brakes which stop the urine from coming, are also very close to the prostate. So as a result of the surgery or the result of the prostate enlargement, those muscles can also be affected, and the patient begins leaking urine, and they have to use diapers. Those are the two main feared complications of radical prostatectomy. And that is one of the reasons why we don't just do it on anyone. We must, the benefits must outweigh those risks.
And then quickly, if we talk about when you treat high risk and kill off the testosterone, what complications do we expect?
One, loss of libido, basically erectile dysfunction. But once you take out the male hormone, then you technically feminize the patient. They'll grow breasts.
I was afraid of asking this question. Does the man now stop being a man?
It depends on what you call a man. Yes, they continue being a man, but they are not going to be able to get an erection, so they're not going to be sexually active. They're going to put on weight. The bones might get a bit softer. Like I've said, the breasts enlarge. They might begin wrestling with the wife for bras.
I want you to tell us one thing. What is the correlation between frequency of sex and prevention of prostate issues? Because that's something that everyone talks about. Is there any correlation between those two?
The studies keep flipping, and quite a number of them don't make it to publication. The current trend is more towards preventative. So you have the studies which are coming up that frequency in sex is protective to prostate cancer. And the frequency, we're not talking about every day or every so often, once a week, once in 2 weeks, at least something in a month that is preventive enough. Yes.
Okay.
So there's a degree of prevention.
There's a degree of
prevention. But the evidence is not yet too strong.
But what are you then saying about the people who are undergoing chastity, widowers, people who are abstaining?
The risk of prostate cancer has not been found to be much higher in those who abstain or much higher in the ones who have frequent sex.
Okay.
We can pick the marrieds and the religious celibates.
The ones who have undergone, who have vowed to chastity.
Yes, chastity.
Or those who are abstaining.
Yes, the risk is not any different. But the current evidence seems to favor the ones who have more frequent sex. But it's not much more than for the ones who abstain. And I have treated prostate cancer for the last 7 years. I don't recollect having treated any reverend father or anyone abstaining for.
I do not know if that shows that they are abstaining and we are not getting this, or they are also part of those who are benefiting from.
At the very worst, they are the ones who have less frequent sex. Yes.
Okay, all right. No, but that is encouraging, so that people who have vowed, have made your religious vow or just made a decision to abstain, please go ahead and abstain. Do not use prostate cancer as a reason to break your vow to whoever, to your covenant with whoever you made it. So thank you very much, Dr. Simwe. Remember, we shall answer all your questions that you may have on the prostate and prostate cancer on our social media platforms. Follow us on Twitter. Ask us your questions on Facebook, and remember to subscribe to our YouTube channel, Doctalk Show. See you next time.
UBC, inspiring Uganda. This week on UBC.
We're all on a journey. That is how it is. It is labor externalization is what we're going to talk about, and what is affecting the sector, and getting to know his story for the entrepreneur out there who wants to tap in this particular sector. I'm having Ashi Chitandwe, and we're visiting this beautiful place, Great Breeze, right here in Jersey Limited.
I want to tell you something very interesting. I actually didn't even have the money. Even when I was beginning, I didn't have it. But because I'd made a very big network of friends, I was able to just land on one person who was able to connect me to someone else who had the money, and they were willing to actually lend me that money, and I pay them at a later stage.
One-on-one with Michael Jordan Lukomwao.
A weekly face-to-face conversation focusing on accountability, inspiration, information, and sensitization of the public from the various sources such as inspirational profiles.
Having a disability is not inability.
Professional guidance